And this panel is going to be led by Joanne Yu. She is the Deputy Executive Director of Asian Americans for Equality and also previously served as the Executive Director of the Asian American Federation.
Good morning, everybody. Good to see all of you. I always love to be in a room full of Asian people. I'm going to tell you something, in New York, all the things you take for granted, it is the beautiful diversity of the city. Like there's nothing as comforting as being in a room full of people like you. My name is Joanne Yu. I'm the Deputy Executive Director of Asian Americans for Equality. Some of you know who we are. We actually are a community development organization. We're celebrating our 52-year anniversary. We built affordable housing. We built the first shelter, transitional housing for women who are leaving domestic violence situations. And the space is big, there's 90 units, and the space is designed so that women can leave with their children, because that's a lot of the reasons why women decide that they don't want to leave. So it's very exciting. And one of the things we talk about all the time is mental health, what is happening in our community. So Asian Americans for Equality, our gala is coming up. Please look us up. I will stop my intro right here, but I want to get to the meat of the conversation. This is the community trauma, safety, and well-being conversation. I hope you're in the right place. So I'm really glad to see all of you. I'm glad to see so many friends here. We are here to discuss an issue that I always feel like is a taboo in our community. And I'll tell you that this has been a personal passion of mine for a decade, because we're a group of Asian Americans in the room, and everybody has, we're telling stories, everybody has a story to tell. And we all talk about our own family stories, personal stories, and how the traumas that we have experienced or we see around us just never gets talked about or addressed. So when Isabel asked me, can you do this? And I said, of course, don't let one of your best friends suffer you into I'm honored. Like all forbidden issue, we have to shed light on how our communities deal with mental health and mental wellness. There are so many community members who are suffering in silence when there is help available. By holding these types of discussions, we can lift the veil, show everyone that there are solutions and help available to them, and that no one should suffer, especially suffer in silence. We have some super smart people with a lot of alphabets after their names, and I'm excited to introduce them. I'm going to let them introduce themselves, but I'm going to go right down and start with Doris.
You didn't see me kind of late, did you? Hi everybody, I'm Doris Chang. So lovely to be here with all of you. I'm a clinical psychologist by training and a professor. I see you, sorry, a professor down the street here at the Silver School of Social Work. So a lot of my job is really training clinicians, bachelor's level, doctoral level clinicians on how to be more culturally responsive in their care. I also do research on promoting equity in medical services, and some of that is taken in the form of culturally adapted interventions. And then to address the workforce shortage of Asian American clinicians, some of my research more recently has focused on how we can train white clinicians, dominant group clinicians, how to effectively bridge differences in treatment. So excited to share some of the findings from some of our work.
Hi everyone, I'm Aparna Kalbag. I'm a research scientist at the Rutgers Institute for Health. And we have a center, the only one in the country, so we're very proud of it, the Center on Asian Health Promotion and Equity, and known as Excellence. Isabel is one of our community advisory board members, and we are so lucky to have her and her expertise and a really wonderful board that informs all of the work that we do. I'm also trained as a clinical psychologist, so my research interest really is on what are known as cognitive models of illness, which is how we think about health. What are the ways that we imagine what it is that we're experiencing, the symptoms, etc., and how that affects our decision-making about accessing help. So I will be talking a little more about that today, and I'm excited for all of you to be here.
Chang?
Yes, hi, my name is Jihan. I'm a psychiatrist. I work at Hamilton-Madison House, already got some shout outs here today. It is, just for those who don't know, Hamilton-Madison House is the largest and leading behavioral health program in the East Coast that has the most caseloads for Asian and Asian American diaspora family. And I believe it's the second biggest in the country. Very happy to work there. I've been having a lot of clinical experiences and services for clients from age, really, for me, I'm an adult psychiatrist, but I worked with people from 17 to age 90, so I've been seeing multiple generations of Asians and then their stories they bring in, and so it's been very informative to learn about my place and also my identity myself as an Asian American. I work in various settings from emergency room, patients, outpatient, intensive outpatient, so I've seen people from all stations. And so that's something that I would like to bring more into this, discuss more different types of forms of illnesses, but more importantly, just focusing more on the culturally competent care piece and how we can deliver this, because I know there are a lot of clinicians here. I would like to have discussions about how to do the work better.
Little known fact, we are actually related. We found out on the Zoom call. We come from a very small line of the last name. So we came in 72, so I think that's why Innovation chose to spell our last name, but it really used to be spelled like that, right? RYU, right? So it's like, oh, what? You are you? And you say, I'm the little you. That's me too. Our family, did you know that our family went from converted Korea from way back in the day from military government to democracy. So that's what you're going to say. So I'm very familiar with Hamilton-Madison House. Isabel is a dear friend, but also that's the model that a lot of the New York City groups use to say, this is what we aspire to, this is what we have. And I do want to share a story with how community networks, why they're so critical. Several years ago, I think it's a couple summers ago, before I stepped down from the Federation, there was a shooting in upstate, and it was a lone family. It was a little boy, 13 years old, he had just graduated from middle school, right? He was so excited, he went to a party. He's coming home, and a cop stopped him and said, what are you doing? He had a black hoodie on, because we all know black hoodies are supposed to be signal something horrible. So they stopped him and they basically put their hands all over this kid. He was really traumatized. Because in their culture, in the Hmong culture where they're coming from, cops meant military, which meant they're gonna arrest you, and in a lot of countries, sometimes when the military picks you up, you don't come home. So he got scared and he ran, the cops shot him, and he died. And it was news for a little bit, but the community, because it's so small, they didn't have resources. The mom actually needed to talk to somebody. She didn't talk to a therapist. We called Hamilton and they said, we're looking for Isabel, can you help me out? Who do we know is a Hmong speaker? How do we help this mom? Because the side story to that is the mom actually, I'm not telling you any of the things, it's literally the paper. The mom had a stroke, and the mom did not want to go to the hospital because that's a hospital where she had to identify her kid's body. So there's all this trauma upon trauma. We determined there was no Hmong mental health clinician. We had to use a translator, but sometimes translation is kind of weird. Sometimes translation is just literal translation without understanding all the cultural nuances, hence cultural competence. I tell everybody that hill I will die on is going to be remote access, because if you don't communicate with people in the language that they speak, we're always going to be back to the same place. It was the weird web of finding random spaces to piece together help for the family and the community is so traumatic. It was an instance of, in New York, the one major, we have a couple of clinics, but the one major go-to is Hamilton, and Isabel was already like, you know what, Mom, that's a tough one, right? That's a tough language. So even with all of our best efforts to try to meet the demands, at times it seems that we hit a brick wall. And so I think this conversation is really important because we do have to talk about what trauma looks like, also what is happening, but also, more importantly, what is the action item that we all walk out there with? And I'm very interested in that action item. So I'm going to start with you, Jihan. Because you work in the community, what are the most pressing issues impacting our community right now? And how does that show up in your work?
Okay. I think I would say trauma is the common denominator of everything that I see, to be honest. Doesn't matter diagnostic labels, where they come from. And I know that like the DSM, for those of you guys who don't know, DSM is sort of gold standard for how we diagnose certain illnesses. The trauma is very specifically defined as something that is very life-threatening and that should happen to you in real time, or observing it, or yourself. But and to be honest, that is the right way to diagnose trauma. But also, I can see all variations of trauma in our lives or in our patients' lives. Something that maybe not as traumatic, but in the moment, like 9/11 happened to you, maybe accumulation of microaggressions that people are receiving just because of their identity, or the type of trauma, especially the ones that I see the most commonly, is intergenerational trauma, which is defined as transmission of your previous generations of traumatic experiences to you and to the next generation who didn't directly experience that trauma firsthand, but they still live with it in terms of their coping skills, in terms of their emotional stress burden in general, or their personality traits even. So like I've been seeing a lot of remnants of long time ago trauma that can be anything all the way for Asians to, I don't know, like World War II, occupations, military dictatorship. A lot of families leave their countries, their parents or grandparents, because of their political issues. So even though these young people that I see sometimes, they have no idea what they are, they just read about it on TikTok, but they just are living with it because of their own like growing up environments, or what they is normal response to stress. And so, long story short, I just see very varied forms of trauma that they carry in their both brain and their body, and it's been really eye-opening because I have to see them like every week or every month, so like I get to see how they really unfold, and sometimes how it's so hard to talk about it. I think some of the themes that came up earlier is like how we don't talk about it. That clearly is normal in some of the severe forms of clinical issues that we see. And so a lot of my job is to kind of, even myself, identify that this is a trauma, even though it's not particularly PTSD, I just need to accept it as such, and then like really think about like how to have this conversation longitudinally. So that's the first thing that came to mind in terms of how it shows up in clinical work.
Okay. With my work, which primarily is research oriented, as well as sometimes doing presentations in the community, I would say that there are both internal as well as external forms of trauma that we end up seeing. And the way that that shows up in Asian and specifically South Asian communities are more physical illness. So as some of you may know, we have one of the highest rates of unexplained physical symptoms, conducted with headaches, backaches, and a lot of that is unprocessed mental health trauma that shows up in these physical symptoms. Substance abuse, in terms of LGBTQ communities, you see a lot of depression and anxiety, a lot of times because our community itself is not accepting, families are not accepting, and then you have multiple levels of hate, I would say, hate crimes that happen, not just because of their identity as LGBTQ, but also as Asians, as a minority group, as an immigrant, as someone who doesn't speak English, etc. And then the other thing that I think we see are actual physical illnesses have become much more sensitive to that since I started at Rutgers, which are things like cardiometabolic diseases, which are very high prevalence in South Asians. And a lot of that, my clinical interpretation is that a lot of that is unprocessed trauma from multiple generations that had to deal with, colonialism back in the day at home, but also the immigration stress that families are now accumulating over the generations.
So I guess I can speak from the position of a researcher as well as a clinician, so I do see patients in private practice. To amplify some of what you were just saying, my colleague Mia Ozaki was talking over here in this department, and I did a pretty large scale survey during COVID to assess experiences of other discrimination and also psychological distress in 2020 and 2022, and we did find that LGBT Asian Americans and also mixed race Asian Americans have the highest level of psychological symptoms. So we can think about in the research, those are two really understudied populations. We don't know that much about those intersections, but clearly we need more research, and we also need to be aware that these are groups that are experiencing intersecting forms of oppression, they're intersecting forms of trauma, and it does show up in the data. The other thing I wanted to mention is clinically this issue about intergenerational trauma. So I do work with, I would say, middle-aged adults, some young adults, and I'm also doing a clinical trial with Asian Americans in the community. And I would say that intergenerational trauma shows up clinically in very different ways depending on the age of the person. And so one theme I keep seeing, just as a side, working with white clinicians to explain Asian Americans to has given me a new appreciation for that sort of, as sort of an outsider looking into the Asian American experience, like, oh yeah, we need to explain some things to them. And one of the things that we see often is that these clinicians are saying, my patients are really hard to read. So there's like an affective blunting that we see where clinicians are like, I can't tell what they're thinking, I can't even tell if therapy is helpful. They're sort of flat in their affects. I don't know if what I'm saying is landing. I'm like, oh, they're flat. Like I almost don't register it because I'm so used to having to work hard to empathically attune to what other Asian Americans are feeling. Like we may not necessarily verbalize what we're feeling, and that comes from my clinical experience from their parents not prioritizing their emotional experience because they're so busy in that immigrant generation, for example, working hard, putting food on the table, dealing with their own stress and trying to not let it affect the children, that they're sort of affectively cut off from that aspect of their experience, and that does affect their relationships. So these kids are not coming up in their 30s and younger going, like what you want me to express my feelings? Wait, I have to, that's helpful to do that, and realizing that it is having an effect on their emotional life, it's having an effect on their relationships, and it's having an effect especially on their relationships with their parents. So I would say it may show up in these quiet ways too, but it's definitely having an impact, and we see that a lot with research clients.
Yeah, I first was made aware of generational trauma when we did a walking tour of the Southeast Asian community in Bronx. And it was interesting to talk about the Cambodian Vietnamese experience, the refugee experience. When we turned a corner and got to this residential area, all these little heads popped up of the aunties and the uncles. And we're like, why is this the building where everybody lives? And they said, why is everybody on the second floor? Because that's a generational trauma that they have told themselves, we can't go up into any higher floors, basically camping in the one house. And so the kids have to live with that. When the Federation did their mental health report, we included a section for LGBTQ youth. And for them, it was particularly difficult because many of them are students and they're on their parents' insurance. And so the parents might look at a bill and see, oh, you went to go see somebody, what did you talk to them about, right? And I have friends who are mental health clinicians who are like, they're Asian and they speak, many like Asian languages are fluent. They say, I don't want to see Asian comments because parents don't realize, I can't tell you anything because you're not my patient. And the answer is, well, I'm their parent, so I have the right to know. And it's like, that's the reason why a lot of young people don't go seek help. There's a lot of trauma happening. There's a lot that they have to process. A lot of them are the language and cultural brokers for families, and that's also really hard. I want to unpack a little bit about some of the things that we're seeing now in this political climate. About the anti-immigrant fear and the sentiment that is just running rampant right now. Because even if you're a citizen, I have citizen friends, I'm a citizen. I take pictures I carry a picture of my passport with me. And I have to brace myself anytime I can be stopped and we ask for ID. And for me, that's a little bit of a trauma, right? Because I'm thinking, I'm a US citizen, I'm paying taxes. But that's something that I feel a lot of anxiety about. And, and then working backwards, we also had anti-Asian hate, anti-Asian sentiment by our president. Every time something happened, call it China virus. And we were, I know Daphne's in the room somewhere, but at the Federation, we did all the anti-Asian hate responses, and we can clock when the hate violence was going to go out, because that's when the president was saying China virus, Wuhan virus, and we're like, oh, everybody brace yourself because the numbers are going to spike up. So we have these, it's not just, privately at home, but it's also our families responding to what is happening on the outside. So can we talk about that in terms of setting the goals?
Absolutely. Obviously during COVID, we really saw how political rhetoric, especially connecting COVID to an ethnic group, had a direct impact on how people treated Chinese and other Asian American groups. So we see that in the data. There's some really interesting time series analyses that actually do exactly what you're saying, which is track when President Trump tweeted something and then the number of hate crimes reported that within this 1 week later. And then it would kind of go back down and then something else would happen. So people are very sensitive to what we call racism in the air. So social media, the way things are framed, gets into our consciousness, and then people do start to associate Asians as threatening. And so there's a lot of data to support that. And even now, especially, as you said, there's a lot of fear, there's a lot of anxiety, there's a lot of questioning about what it means now to be Asian. For folks, there was a period of racial awakening, I think, during COVID for a lot of Asian Americans who thought, especially we saw this with East Asians in our data, who thought oh, we're doing pretty well. It's been a while since we felt really targeted. In fact, Crazy Rich Asians was made. There's positive representation. And then COVID happened, and so there was a moment of wait, what? We were playing by the rules. We were doing everything right. We were achieving. I have this great job, and no matter how hard I work to assimilate, to be a good member of society, I'm always going to be seen as this perpetual foreigner. And so that led to a crisis of reckoning with the fact that we do live in a racialized country. It doesn't matter if you're a good minority or model minority. You're still going to be scapegoated, especially during times of economic and political crisis. It's like you can see this over history. So what we've seen now, we're doing some qualitative interviews with emerging adults, so Asian Americans aged 18 to 25, for whom identity development is a really critical task. Right? They're really grappling who am I? What does it mean to be in this body, in this society? And trying to make meaning around that. And we interviewed Chinese young adults, Filipino young adults, and Indian American young adults, and have found some really interesting differences in how they're navigating this particular moment. For some of them, it's like a crush and blow to like surprise, and for others, they're like, yeah, I knew that this my family's talked about this forever. We definitely saw a lot more racial consciousness, critical consciousness among our Indian Americans. Compared to our East Asians, who I think really bought into the myth, that you just work hard and then you can escape all of this, and grappling with seeing their Asianness as a liability, especially as they're applying to college, as they're applying for jobs, and what that does to a person, just sort of wonder, oh, is this going to be held against me? Because we're now having to compete for other slots. And people expect us to be smart and high achieving, but then they hold it against us who we are. So we're definitely seeing that in our data. This is a conflicted identity development process. But on the positive side, and I hope you talked some about the incredible resilience also we're seeing in this community. Many of our participants have talked about how they've gravitated to social media as positive role models for how to navigate this period and finding Asian American, Asian influencers who are talking with a lot of pride about their identities and like claiming that as a positive aspect of self and learning about Asian and Asian American history, because that's not something we're taught at school. So having to do all that extra work to feel a positive sense of belonging. But they are doing it, and they were coming out on the other side. If there is a silver lining to all this, and many are coming out with a stronger, more positive, affirming identity through this process of grappling with it.
So part of my question to you is same, but it's a little different. Because I would say, no, for Aparna, so, after 9/11, it's just so hideous, right? Special registration, all of that. And also, now there's just open anti-Islam, Muslim sentiment that for some reason, because of ignorance, obviously racism translates to every brown person. It's open season these days, and people are so shameless about just saying these things because it feels like for many of us, there's like no real consequence, like no sane person, no part of that, but no person would ever think that way because why would you equate this? So there's always a sense of like you have to guard yourself against this perception of South Asians, Muslims, Middle Easterners. So can you talk about it a little bit with your experience with that?
So I think, post 9/11, I definitely saw this within my own ethnic group, which was Hindu Americans, who would be very clear that I am not Muslim, like that would somehow protect you. And I think this is again part of that model mind argument, where we attribute positive characteristics to ourselves and negative characteristics to others, right? So instead of gathering with our Muslim brothers and sisters and saying, we're here with you, there was a lot of division. And that's exactly what these sentiments that come from outside our groups are meant to do, is to fracture. So one of the things that I think, when I think about resilience within our groups, what I see is that there is a lot more connection across religion, across subgroups even within South Asians, whether it was an Indian and a Pakistani or someone from Sri Lanka or Nepalese. I do see more connectedness and around things like LGBTQ identity, or yes, I'm depressed too. So we are seeing that when you connect with someone, just based on your lived experience, you do find that the ability for others to kind of divide you internally and within, the group, that's a force that can't be reckoned with. So it's wonderful to see how our communities have responded to that. One of the things that I wanted to point out, again, with the model minority myth though, and South Asian groups that I've seen, is a lot of or what I would call colorism. So I see it in my own family with my 60-year-old who loves to play sports, is outside playing soccer, running track, and every day as she gets darker, she comes home and balls because she's getting darker. And I'm like, who is telling you? Like, we live in a probably 30% Asian community in New Jersey. I'm like, who is telling you that you're not beautiful? Like, it just, and I can see that some of it is coming internally. I've heard her friends say that right to her and, you know, in front of their parents, and I'm like, really, you're okay with this? So, you know, one thing that I would like for all of us to do in our own individual families is to speak up about these things. When you hear hurtful comments about other Asian groups, about someone who's darker, and this model minority myth again, what is that about? Oh, Asians are supposed to be the smart ones, the other minorities, Hispanics, Blacks, are not as well off as us. And I would really ask all of you to speak up in your own families and communities when you hear that, because it does end up affecting our own self-perception. So I just wanted to share that.
Tell your daughter white people pay for those payments. Jihan, my question for you, because you mentioned you work with youth and with seniors, are there commonalities that you see as they process what is happening to them, what they see outside their doors about being Americans? Is there a commonality that you realize, oh, they do kind of understand and they're kind of making the expectation?
Connections around their
What they're processing, their emotions, right? Like, or are there people, are they, I think the young people are a lot aware, because I follow a lot of Instagram young people where they talk about their mental health journey, and some of it is just so heartbreaking. I watch some of it and I have to shut it off because I have to cry, because they're dealing with their parent trauma, right? And they said, I don't know how to get out of this. But young people are becoming aware. Are elders who are becoming aware? And are there times when you see like, oh, here are some things that they're all aware together, and maybe this is the problem starting like full conversation.
So I think I see 3 generations, like so Gen Z, millennials, and then Gen X together, and then like boomers, like the generation. So I would say that's why I a little hesitated to ask the questions and before answer, because they're all in different worlds, to be honest. When I talk about emotional stress, what that even means, all have very different definitions, all have different thresholds at which they seek help before they think it's okay to ask for help. Meaning seniors and older generation tend to be a little bit more shush about these things. I hear even sometimes some seniors saying that, we work so hard to come to this country, like what you're describing, like listening to Gen Z, patients, is like such a privilege that you can't really afford to be anxious or depressed, like see how much work we have done. Like those kinds of, I would say, toxic comments. I mean, they come from, I understand where you're coming from, but also obviously it really limits empathy, right? It really limits why these children are showing these behavioral problems, and that is why we're even here. And so some of my work is, like you're saying, like to really bridge 2 or 3 different narratives and really saying that these are all valid narratives, but obviously there is disconnections. So I think it's like, I don't think it's just Asian specific. I think it's just a generational thing that I don't know that there's a lot of research on, regardless of, mistakes. But yeah, a lot of the times where they connect though is through their own shared family experiences or immigration experiences, shared values, or some of those things where they can find common ground is where we want them to be first at before even having more intense conversation about emotional distress. I would say, like, I consider that even though they're same, like, say, Japanese or same Korean families, they're all very different emotionally, and especially if you grew up in New York City too, and the Western, culture, and they can open a different lives, eras of US history. So that also affects how they think about when to ask for help or what are the things to ask for help. I would say like really younger generations, sometimes I would say even over mythologize themselves, where they just think that they're mentally ill when they're just normal. And so some of my work is actually doing the opposite. And so the first you need to say, hey, this is not normal, you really need to say this is not okay. And then for young people that kind of just say you're okay. This is all responsibility for up with your girlfriend, you know? But I think there's some like elements of ethics here, influence in social media obviously as well. So I think every generation has their advantage, to be honest.
So how does, every community, whether you're Asian American, there's a lot of collective trauma that we hold, historic, systemic violence. How do you think that collective community trauma shape the impact of how we understand community safety and mental well-being in our communities? I'll start with you.
So I do feel like the levels of community trauma that we don't address ends up coming back at us that much more strongly, right? And I think in the lived experience panel, we talked a lot about naming what it is, what your illness is, what you are suffering from, which tends to alleviate 50% of the problem. Once you know what you're dealing with, it doesn't affect you as much. And that's one of the basic tenets of going to therapy. It's just naming a symptom, naming what it is that you're up against. Once you do that, the next step is to learn how to cope with it. And so living with your symptoms. And similarly, I think that is something that as a community, whether you consider yourself, Asian Indian, Pakistani, Hmong, that's one of the ways in which we can identify what are the traumas that our people, whoever that reference group is for you, have to deal with back home because we're carrying it. So again, understanding your history more is really important. And then once you come to the US, what are the new traumas that come as an immigrant? And respecting that somebody else's experience may be different than yours, but to still validate that. And I think that younger folks in the room, as well as in society, tend to do a lot better job than my parents' generation or even my generation as Gen X. So I think we're headed in the right direction, but the more we can address some of these issues, the more we can collectively reduce the effect of the trauma. Acknowledging it is the most important factor, I would say.
Doris, same question.
Okay, I wanted to also acknowledge the effect of vicarious trauma. So we're talking a lot about things that happen to you directly, or things that happen to your family directly. And so in the research coming out of COVID in particular, that's really looked at the effect of knowing traumas are happening to your community, has also shown that that is associated with increased stress and mental health symptoms. So if you care about other Asian Americans and you know that other Asian Americans are experiencing something that actually does affect your mental health. So I think one, validating that counts as traumatic, not just things that happen to you directly, I think is important because that's probably part of the naming, right? So my question was in between of songs. What else was I going to say about trauma? So the other thing I wanted just to bring into this conversation is around one effect of knowing that you may be the target for prejudice or discrimination. So during COVID, a lot of the media, and I think this continues today, a lot of the media discourse around Asian Americans being the target of racism and discrimination, especially on the streets or in the workplace, depicted the primary perpetrator as Black. And that story, that narrative was really spread throughout ethnic social media as well. So, stuff that your mom, your grandparents are kind of sharing and back and forth and videos and things like that. And I think it created a lot of really divisive fear in our communities. It's another example of driving a wedge between Asian and Black communities together. So I was really curious about that and dug a little bit into the data, and it turns out that if you look at like national crime statistics and national hate crime reporting, over time, the biggest perpetrator of hate crimes towards Asian Americans are white people by a multi-factor amount. But we don't ever hear about that. And we don't ever say, actually, you should be afraid of all those white people in our communities. So it's like practically false, this idea that African Americans, Black Americans harbor this kind of negative racial sentiment towards Asian Americans. Like that is actually a myth that is being created by the media and the way that we share it and our internalized anti-Black racism is so harmful. It's so harmful to how we feel in communities, it's harmful for solidarity efforts, and it's just actually a lie. So I think it's really important for us to be critical also of the media that we're consuming and actively question what the narrative is about who we should be afraid of and what's the real threat. And to your point, like continue to raise that and challenge those ideas that are really pervasive in our communities and are actually not grounded in the data.
I remember being interviewed by media the day after the white guy walked around New York City and punched out some Asian woman. Some brothers, one Sunday afternoon. And I was doing an interview with somebody out there. They said, isn't it true that people have a higher number of attacks against Asians? And it's like, have you been watching the news? Like, what are you talking about? And I think it's really important that we have to call out that perception because that is exactly the problem. Because, I also got asked a lot of questions from our own Asian community, our Asian leaders and elders. Why do you think Black people hate us? That's the prevailing sentiment. So it creates this fear of, every time I see somebody who's so much like me, Black people, I have to be scared. And I said, why would you say that? Well, how come nobody's standing up for us? And and my response has always been, well, I know that whenever something horrible happens, it's usually my Black friends who are the first ones to call me, and the first thing they would say is, don't look at the news today. I need you to not look at the news because you are not going to be okay, right? So maybe you just need to get better friends, and maybe your friendship has to be more diverse because plenty of community members, plenty of people are outraged, but it's also the fact that there is that narrative, it takes it on more than, and I've been following all of these. I spent all my evenings watching Instagram, watching how this racial discourse is being processed right now in this country. And it's so interesting because now non-Asians are starting to understand, Asians are now challenged by this thing called the non-minority myth. And this wedge is used to harm us. And it's been so enlightening to think it's not, we have to be our own ambassadors, but there are other people telling that story for us. In turn, we also have to be ambassadors for other communities. I know that Isabella and I know a common mentor, Dr. Rosa Gill, who has retired from communal life. And she is the one who always said to me, look at the numbers. Asian community has a huge mental health number. There's tremendous risk and nobody's talking about it, nobody's inviting you to the table to get there. So when the Governor Bobo convened the mental health, Asian American mental health roundtable, Dr. Gill was a lone non-Asian because she was the expert in how to talk about trauma, how to process, and it's because you don't have to be Asian to stand up for Asian communities, just like you weren't. You don't have to be Black, you don't have to be Latino, you don't have to be white to stand up for other communities. I think reciprocity goes a long way. So my community, Jihan, same question to you is, how does collective community trauma help to shape public safety and mental health.
Yeah, that's shocking statistics. I did not know about this study. Yeah, and just like what I hear is that how powerful misinformation is. In thinking about these topics, so we need better source of information and leadership. So that's the topic about how it relates to mental health and in individual emotional lives. I mean, one thing that I really frequently notice is, I think this word came up earlier at the panel too, but like self-stigma, like silencing yourself about these issues, or even really believing in minority myth, like as truth of their own destiny. Like I sometimes see this in all generations. So that's one common thing that is younger to older folks in ancient generations. They really believe in it, or they really think that they're unlikable, or they really think that they should show their esteem through high achieving whatever status, money, wealth, and education, and that's the work to be done in individual therapy. Is it really what you really wanted, or is it what the society told you to do? And if this is what you really want, why are you so unhappy, even though you have these things, or you're so well off, and like you're still drinking so much? Like I just have to understand like why is there such disconnect between what you think you should have and also how you really feel inside? Because a lot of our work is about internal work and then really identifying emotions, seeing the patterns of like maladaptive skills, coping skills, different narratives. Like those are the therapy, right? And so I've been seeing a lot about this self-instilled stigma, and some of it is not individual. It's definitely not they want to do this for themselves, but I think it's definitely coming from larger social forces, influences from political things that we were just discussing. So, in other words, sometimes it's hard to do this work because like I can't change somebody. Obviously, the whole society and community needs to change too. So this is one of the reasons why we're here, right? To just to educate and to learn about how to other people. But I think at the end of the day, if you're a clinician sitting with this person across the room, you'll just have to be very honest with them and say, like, this is really what you want. And clinicians themselves should be very honest about that too, right? Like we should be impartial and neutral enough to have this conversation. And sometimes there's a lot of defenses coming from people saying, but what do you know about this? Like, but like that's the conversation, that's the work. Whenever there's a tension, I think there's sometimes opportunity for progress. So I try to sit with the discomfort too. But yeah, I think this self-stigma is a real thing. And I'm always wondering like how do we do this? How do we get through this as a community? That's my question always proposed to.
Do you want to add to that?
I did have, because I think you brought up a great point, which I think as a clinician, one of the places where we can do our clients a lot of help is we've talked a lot about sort of societal and external environmental factors that are now affecting our functioning. But really to get down to, so then what do you have control over at that individual level? And that's something I think that Asian communities, Asian families, we don't talk about. We're always talking about the collective. So I think that helping your clients find where are the spaces that you can help the person affect change in their own life is very powerful, even if it means, sort of, this is that very Western concept of let it go and let them be, but really to allow whatever is happening to allow it, because we can't fight all of it all day long, right? We're going to tire ourselves out. But what are the small changes that I can make? Who are the people that I can become friends with? Who are the family members? Who are my allies? And identifying that can help you stay safe in this very chaotic environment that we've described.
So could we talk about what efforts you've seen that has been effective and you think, oh, this is a really great clinical effort, research that really leads to, I feel like numbers always have to start because that's how we really put our case out there, right? So many years ago, I talked to a funder who said, there's so little information on Asian American community that if you just scribble some number down on a piece of paper, and if you can get it to Google right number 3, you probably have something, right? Which and said because there's so few data, there's very little data because first of all, when people call me for it, like could we survey you? No, I'm gonna talk about it. It's the same thing that like we're not really engaged in that way, right? We're not built that way. So I think everything has to start with numbers and data first, but then there are some community responses. I'd love to hear some of the research that you both are doing and the future about how what has been affected? What have you seen when we were like, oh, maybe we'll have an aha moment, as a community? So.
To address some of the stigma around mental health care seeking, I think the research coming out around school-based services has been really promising. There are a number of folks who work in the space around studying the effect of having groups to talk about racial and identity development in schools. Right, so we're not necessarily stigmatizing like, oh, this is the group for the kids that are struggling, right? But it's also acknowledging that it's an important developmental task of grappling with who you are and trying to find a way to develop a really positive sense of connection to your heritage group buffers the effects of all kinds of stress on well-being. So it's an important mechanism that we can fully nurture that will it's kind of like will inoculate them from the harmful impact of a lot of this environmental stress. So I'm thinking about Anna Lau's work in schools in California, and Linda Duong also studies this in Europe and has found really good outcomes. And also Adriana Taylor at Harvard, where they have a curriculum, like an 8-week ethnic identity development curriculum. It's a group-based intervention. It's been rolled out in a lot of different schools. And it's been tested with a lot of different ethnic minority groups, and it's really finding that it does seem to strengthen and ground individuals in a positive sense of self. So I think that work is really a great way to address the lack of help seeking among that population of parents. They internalize this lot of stigma around being urban their kids and see therapists. Meeting them where they're at in schools is, I think, a really important strategy. And then I'm also just thinking about some of the work that I've done to try to leverage cultural strengths that we have. So the evidence-based practice world typically starts with an evidence-based intervention that has been developed primarily on white majority groups. And then we figure out where it doesn't fit with different ethnic minority community groups, and we try to adapt those components and not change the critical ingredients of care. But I think we can also do a lot more to consider what do we have in our own communities, our own practices, in our own belief systems that actually promote well-being, and try to integrate that more explicitly into your clinical practice. One example of that is some of the work I've done on Taoist-oriented cognitive therapy that came from China. It's funny, it's a reverse adaptation, and then we brought it back to the States. But essentially, folks in China in the 1980s developed this short-term cognitive-based Taoist integrated treatment to address the fact that a lot of the folks they were seeing in clinical care were illiterate, and they also didn't want to spend a ton of time in therapy. Right, so they're like, can I just come in? In China, they have something called psychological consultation. So you just come in, you're like, doctor, here's my problem. What should I do? And then you get kind of like advice, actionable strategies, and then you go away and maybe you never come back, right? It's an interesting model, but in any case, they were realizing like, people are saying we need help, but they want to come in every week for an indefinite number of weeks. What can we give people? And they found that they developed 8 Taoist principles that they could easily memorize because it's written in the form of the Chinese couplet. And they could take that in with them. And in times of crisis and stress, try and imagine what would it look like to respond from this place. So there were principles that could begin to shift the way that you think about the world. And what was nice about that is there was a lot of credibility around these. They're like, oh, these are ancient wisdom traditions that have been, helpful for thousands of years. There must be something good here. So we manualized that intervention and actually tested it at Charles B. Wong. And what's interesting about that is like this experience of saying, our community actually has something really novel. We may not need to start with treatment development for minority group members and adapt to our communities. Our community actually has a lot of cultural wisdom and cultural strengths that we can start to integrate into medical practice. And so for me, it was, I think, really a culturally affirming experience of having to develop that intervention. I think for the clients, it was affirming to recognize some things in the treatment as home, as things that they had grown up hearing, and then saying that actually is a helpful way to deal with some of those problems. So just encouraging us to think about what else can we leverage, what else can we harness that comes from our own communities, and integrating that more intentionally into our practice.
Oh, I love that. I think it's a cultural familiarity.
Yeah.
Makes it really comfortable from that and comfort.
Yes.
Great.
What I'd like to point out, just for all of you here in the room, I have 2 flyers out on the resource table. One is for a group called DC Rainbow, Parents and Allies, which is a group that has sort of organically grown in the South Asian community to support the parents and allies of LGBTQ youth within the South Asian diaspora. One of the beautiful things that I see in that group is how they have used, again, the cultural traditions that are inherent within the South Asian culture. We have this practice of bowlies, which is sort of giving a tie around someone's wrist. And what that suggests is that one person is going to protect the other. And really, traditionally it was done by a brother to his sister. But given that we don't want to have those very bimodal ways of thinking about ourselves, we just allow people to have chosen family within that group. And you can choose anyone you want. It can be someone in your family, it can be someone from your chosen family, but that's a way to show affinity and love and care that doesn't have to sort of follow that very traditional boundary ways of thinking about us and them, that it can cross that. The other thing that I wanted to point out, which is the second flyer I have out there, which is called SUMMON. It's the South Asian Mental Health Initiative and Network. And again, a group that has sort of grown organically in New Jersey. Both of these groups want to scale at a national level, so please do interact with them. We would love to connect with other Asian groups too. SUMMON has created support groups. So again, what we talked about this morning about the importance of peer support. And the support groups range in all kinds of topics: domestic violence, divorce, alcohol and substance use. Now there's one for youth and mental health symptoms. So we're really trying to expand and allow for our peers to be supportive of ourselves as individuals who do experience the ups and downs in life. And then one other thing I wanted to point out, which is that within our Center for Asian Health Promotion and Equity at Rutgers, we do have a lot of small pilot projects that are getting funded. They're about $35,000, not a lot, but we're seeing more and more small funded research on specific Asian groups, so we're not lumping all of us Asians together. So there might be a diabetes intervention for someone from Vietnamese heritage, because what they deal with is different than the Filipino community compared to the South Asian community. So I think being able to disaggregate some of that data and to understand how we can develop treatments for specific groups is also a wealth of change.
Thank you.
Yeah, that's amazing line of work that I want to follow up with too myself. I wanted to introduce and briefly talk about the recently funded programming organization called Family Checkup Units, which just started, I believe, last year. So this is targeted for basically children and their parents together as part of the therapy experience. So it's kind of like family therapy, but it's like time limited. You currently finding very, very effective, cases and stories on it. And I believe it is like, parenting session is part of the treatment, in addition to individual treatment for a child, for example. So I just found like, and myself experiencing in other parts of the world too, like involving family in our population is very effective. Sometimes it is ineffective because family bothers you and then like have to be in between. But also if the family is super on board, some of the work that you are doing in clinical group like continues on in between the sessions, and I think that's where real progress happens. And so one example that I'd like to briefly introduce was that this is Dr. Jihan and Swash's case in our clinic. There was an 11-year-old child who grew up in China until age 7 and then immigrated to USA. But mom was here the whole time. She was in second marriage. She herself survived domestic violence from the first husband, which was who was the father of this child. So the long story short, this child has been berating at her mother, saying you're a bad mom, and all these negative words. And that's why the child, the 11-year-old, initially went to therapy through school referral and all that. But then the mom was very dumbfounded and was shocked by like, why are you saying such things? I mean, obviously it's not a good thing to hear, but her narrative, mom's narrative, the parenting session that came up, is that she worked so hard while she was in the USA, like trying to adapt to this new family, new culture. And she thought that like preparing everything to be a perfect home environment setup and liberating the child's aim would be a way to be a good mom. So like she had a lot to say about like, well, this is unfair and what's coming from 11-year-olds. And so obviously her defenses are high. And so whenever child is trying to express that emotions, mom may she's angry at herself. And so like it was apparently very insightful. So one great intervention that this clinician did, and I think took obviously weeks, but is to really create a language and like a space where they can at least listen to each other's stories and why they are having these emotions. Because sometimes, and I think it's again across generations, but maybe in Asian culture, I myself have grown up in this type of environment, but we just tend to say things or like do things and not really pause, right? Because we just get our emotions out of it through behaviors, and that's where the problem starts. But this clinician was really making sure that everybody just pauses and then just like reflecting on what this child was really saying. Also, saying for the child, like, what is this mom really saying? That mom was being a good mom, but this is where she's at. That kind of mediation, core really tenets of family therapy was really effective. And then after that, they kind of a little bit to their own work, on their own. I believe the mom was still a little resistant, but at least she understands the real needs that the child had when she was growing up in China. Basically, she needed, even though she's not perfect, the daughter wasn't really expecting a perfect mom. She just wanted her to be there with her in China, not with grandparents. So that's something that mom learns through this experience too. So just this is an example of how like communication in narratives is such a powerful tool that clinicians have. And sometimes it does take, explicit form of family therapy. And I think family therapy, I hope that this is the type of program that continues on in all kinds of places and religious homes. But definitely in Asian culture, I think making sure that people are on the same page and that they love each other and then just verbalizing it through work is a very effective way to engage and then ultimately lead to good clinical outcomes.
Okay.
And if you want to learn more about that program, there's flyers on our website beside over there. So feel free.
I want to talk about I know it's not prepared questions, but I want to talk about visual research within your teaching, and there's so much you can add to this. But could we talk about the importance of language access and cultural competence? Because exactly what you said, some people some elders in our community are not even literate in their own language. And so sometimes when you go get help for anything, social service related anything, people give you a piece of paper and say, this is translated, so take this home. And it was like, well, I can't. And there's also the shame of saying, I can't read my own language, right? But I feel like the big gap that we've got to jump is language access and cultural competence. So can we talk about that?
what I'd like to bring up is some of the work that's being done at a hospital close to Robert Wood Johnson, which is called St. Peter's University Hospital in New Brunswick. And they have a novel program, again, within the South Asian community, and this is specifically to help folks who are maybe resistant to getting treatment. And this isn't even mental health that we're talking about. This is things like going for regular doctor's appointments, being able to access medication, trying to resolve, insurance issues. And they've used a patient navigator who speaks Gujarati, one of the common languages within the South Asian group. And what he does, which is, Dr. Anna Rodriguez, who's in the audience, has worked with that program. The most amazing thing about this program is that somehow this navigator has figured out where the resources are within the community. So during COVID, for example, there was a patient who needed dialysis in South Jersey. Somehow, when all of us were masked and not leaving our homes, he was able to find someone to drive this patient who was resistant to leaving his house, obviously, for the fear of getting sick, and bringing him and his wife, who didn't speak English, to Columbia University to get their treatment in time. I think that's a great example of how having someone who speaks your language, being able to connect with the resources that are in the community, and to be able to showcase for the community, building that trust that there is a support system. It may not be advertised, it may not be something that you can access even on the web, but the more we can build these informal networks, that's really one way that we can help our communities kind of come out and address their needs more fully.
Thanks for the question. I also agree, language access is so important. And a lot of the community does not know that they have a legal right to an interpreter. For example, like for LMH, New York State funded facility, they are legally required to offer an interpreter if there is not a staff member that can speak it. So not the front desk staff, not that you bring your daughter to interpret for you, but that they are actually legally required to provide an interpreter. So I think some of what we can do is just let the community know that that is a right that is free, they can be charged for it. So many people don't know, right? That is a right that they have in accessing care. The other thing I wanted to just mention is I think mental health has really expanded access to language concordant care. So one of my graduate students just did a research study looking at how she was looking at Chinese and Korean monolingual speaking clients are navigating mental care seeking, and finding that a lot of them are actually seeking mental health services with providers in their home countries, because now that makes it possible, and there are less restrictions in some of those Asian countries around working with a patient that's not in your country or your state. So many of them are actually seeking mental health care in China and Korea and other parts of the country. And so that is now more common these days. And I don't know if you're experiencing that as well, if you know that people are doing that. That's definitely one way folks are trying to access care. And then the third thing I wanted to bring up is I think an innovative way of working within an interpreter-mediated environment. So how many of y'all actually got training in terms of how to work with interpreters in your programs? Like not that many, like 3 of you, 4 of you, right? So most of us are not trained in how to work with an interpreter. And so my colleague Lotus out of Columbia and I actually did a project. One of our data collection sites was at Hamilton-Madison. So I don't know if anybody was around when we were doing that study, but essentially we were trying to play with how to improve the way that clinicians work with interpreters to provide more culturally responsive care, because most interpreters are just trained to provide one-to-one linguistic conversion. But meanwhile, many of them are sitting on a lot of cultural knowledge, and they're watching a cultural process unfold,
and they're like, oh, this isn't going well, but they can't step out of role. And so we designed a protocol for how to expand the role of the interpreter to serve more as a cultural broker and being able to signal to the clinician, essentially, I want to step out of role and offer a cultural observation or a cultural interpretation of what may be happening. And then, of course, we had to train clinicians in how to work in that way with interpreters, because clinicians they want to retain control over what's happening in the session. So there were some power struggles that often happen between clinicians and interpreters, but we were able to show through the research that clients liked it better. They actually, because there's you need transparency, the interpreter would say to the client, I'm going to explain to the clinician the significance of what you just said, right? So they would share something, and the clinician would have no idea what a big deal that was, or actually that's actually a very normal thing that happens in communities. And so we provide a little bit of that annotation in the interpretation process so that there was more cultural context for what was being transmitted. So I think we can think of more creatively around how to work with interpreters, to expand their roles, collaborate with them more effectively, because language access is only becoming increasingly more important.
Absolutely. Share language access.
Yeah, language is super important. I want to also add that just cultural component to not just the language. Language is part of culture, but just the way we properly communicate things, what topics do we get excited about, or do we shame, or do we have shame about? Understanding all of these is part of cultural competence training, and some of these you can learn from book. I would say sometimes you have to see patients and think that way. So I would say one of the things that I think is helpful and will be hopefully implemented very soon and at a wider scale is to just kind of create more clinical rotations that involve minority health, or maybe so that as clinicians, even though this is not what they want to end up doing, they can at least they see somebody like this in their future practice, they can remember some of those cases where, that Chinese family spoke differently about this topic, and I wonder why. They can just talk back their memories, they talk to their supervisors about it. I think without exposure, people can operate out their sort of bias, just assumptions, which may or may not be correct. And so I think education and training is really important. I mean, I myself became very interested in this population through my when I was a resident. I had an opportunity with the medical director now, to just see some Korean speaking patients because I speak fluent Korean, and I thought I would be really good at it, and just because I know the language, but then I also learned just because you're part of this group doesn't necessarily make you a great clinician in dealing with this topic. I think bias goes either way. Either you're ignorant or you're too much. Because if you know too much, you think that you know everything about Korean culture, and I realized, oh gosh, I'm a different generation. I'm definitely more Americanized than these folks that I'm seeing, and I'm constantly having dialogue with my own identity about what it means to be culturally competent. So some of this happens after training, but just overall, I think having some systematic ways that the future clinicians can get exposed to these topics through real clinical experience, through actually doing therapy, and actually going through successes and failures in these cases, and reflecting on it, and really create a genuine community of cultural opportunities as well as clinicians.
Absolutely.
Just an afterthought was also to understand what areas of distress a specific person is able to express their difficulty with. So what I mean by that wasn't very clear. What that means is, for example, there's a professor over at Albert Einstein, Alison Perez, who has studied Bangladeshi women, and she's looking at depression in this community. And because they were more folks who worked with their hands, they were manual laborers, they didn't endure symptoms of sadness or loss of interest. They were like, yes, everything's going as planned because they were very role-oriented, they needed to be moms and wives and doing what they were asked to do. But the depression that they talked about was in pain, physical pain in their hands when they were rolling workies. that's when they felt pain in their hands. And this was something that Allison then, through qualitative analysis, was able to unearth and unpack a little bit, that this is the way that the Bangladeshi community was expressing some of their distress. So as clinicians, I would also encourage you to think about ways in which that you might see patterns across patients from a specific ethnic group in terms of how they're expressing difficulty. It may not be in the ways that we're trained via DSM.
I love the what you said about all of you about universal English access and that there are laws, right? Except our communities are super underinsured now with this fiscal fiasco where people like don't even have access to insurance anymore. We still have kids translating for their parents. And how do you translate? And I will use my own experience. I was a community translator, I was growing up. And I was a new immigrant kid. I came here when I was 9, and by the time I was like 12, I had like a full-fledged service, you guys. And I was like, go to doctors, go to lawyers, translating, and in legal proceedings, I was filling out people's resumes because I was a kid who knew how to do that. I didn't know how to do that, but I was forced to do that, right? There was some trauma in that, I will tell you. And I tell everybody, the one time that I unashamedly dropped the F-bomb is, I did that that was 50 years ago. Why we still see kids do the exact same BS, right? Like, shouldn't we have evolved? Because people don't know their laws. And who's gonna enforce that unless people like us are like, wait a minute, you're gonna have a translator. So I realized like, yeah, it's a law, but how many people know? Because there's supposed to be these language lines, right, for helping people apply for food stamps, but those translators are completely wrong, and you almost have to have your own social worker go with you to do these things, because you're like, well, that's not actually what the person is saying, so. We have a long ways to go. However, I know I've got 5 minutes, so I'm going to ask one final question, and I think this is what we end. So where do we go from here? Obviously I feel like, oh my God, we have all these rich Asian people, throw some money together and fund some research, okay? Because we believe we need to talk about papers to talk about what our communities go through. We need to have more clinicians, we need to encourage more young people who speak the language, who understand the culture, to be able to come into the community to be offered their assistance. So where do we go from there? I'll let you start there, because it wants to go right down the line.
We're gonna solve all the problems right now. I do think that obviously funding for research is important. The funding kind of has been really hard hit by this administration. It's very hard to get research money to kind of research in the Asian American community. So advocacy around that, talking to your rich friends. So money for that. I also think it would be great to kind of leverage community connections and see what novel, interesting solutions community members can come up with. Like, this is a problem, we can name the problem. Like, we've got really creative young people, like, doing all kinds of things we never thought about doing. And so it'd be kind of interesting to actually get some community advisory boards going to say, these are our constraints. We have limited funds, we want to do this, what ideas do we have that we can come up with together? There's cool stuff happening, I think, virtually too. And I think for all of y'all experts in the room, I think we actually need to be creating more content online. So y'all are probably all consuming content, and how many of y'all have experienced like, I can't believe they're famous, they don't know anything. How do they have this many followers? Why does this reel have so many likes? Like, we know a lot more than I think what is being generated by folks who know way, way less than we do. And I think we can develop tailored content for our own communities that leverage like your clinical wisdom, your community knowledge, your connections, and like create accessible mental health content
that is grounded in science, it's grounded in real practice, and start to create the content our community needs, right? Not everybody can access mental health services, not everybody needs to. There are a lot of things that they can do that are just as helpful, just as supportive than going to see a therapist.
And I think we also need to, we can write down, because of funding cuts, it is literally the funding Hunger Games. And so I think we also have to be really generous in sharing those resources, because, you know, it's hard out there. So Aparna, what about you? We're wrapping up. I see you kind of here.
I'll just quickly add that, again, within the South Asian community, what I can share with you is there was a pharmacy that was created recently in Hopedale, New Jersey, Red Bank, New Jersey, in Montgomery County. And this was a pharmacy that is allowing not just for South Asians, but for anybody who doesn't have access to insurance, medications for free. There are some criteria that you have to go through. Similarly, for 25 years now, within New Jersey, we've had a group called the Health Camp of New Jersey that has done free screenings for those who are underinsured and uninsured, and it's regardless of ethnic background. You just have to pre-register and give like a nominal $10, I believe, to register. They do your blood pressure screening, mental health screening, everything. And then they are connected to resources in the community. So I think building the safety net within our communities, somebody's telling me my time is over. So I think being able to build the community structure and support system is very important. And those are two examples I can share.
I think for me, quickly, just ask the actual community members what they need. Really starting grassroots is really important. Sometimes clinicians think that, oh, this is maybe what their problem is, and then we see, but like I'm always shocked by like, oh, actually they need different types of support, or they need a housing application, or, well, this is exactly why they're really sad. And again, looking back to some of the things that we were talking about, a lot of what we do is silencing, and so unless we directly ask these questions about what you need, how we can make it easy for you to access, then we are not really serving the community. So I don't know, just in the future, your policymakers, clinicians themselves, and the organization, just make an effort to reach literally out to these people who are silent and then ask what they want. I think that's the first way to start the conversation.
Could we give a round of applause for all of I wish we could replicate this in every neighborhood, in every corner, to let people know we're talking about it. And it's okay for you to talk about it with us, right? And it's okay to share. Yeah, I'm feeling this way, so what are some of the things that I can do, right? Like, it's a shame that, we are always, it's the Venn diagram, like here's the clinicians, here are the advocates, right? And I wish we need to be able to spread this conversation much further, much wider. Thank you for spending your time with us. I also want to give a round of applause to the organizers, because there was a lot of work.